Many people have written to me on Facebook about what is diabetic retinopathy. It is a very common thing to have diabetes nowadays in India because our people do not exercise, they consume a lot of fast food or fatty food or carbohydrates, and very often our physicians don't tell our patients to go and check their eyes. So diabetic retinopathy is a condition where diabetes affects the nerve of the eye, that is the retina of the eye. Retina is something that is situated very deep inside the eye. Till it affects to a great extent, we will not know that we have diabetic retinopathy. The only option for patients to find out whether they have diabetic retinopathy is to go to an ophthalmologist and check their eyes. And how often should they be doing it? Every year. When should be the first checkup for a patient who's got diabetic retinopathy? Actually, a patient who does not have diabetic retinopathy and instead starts to have diabetes should check their eyes first. Because the first time you check your eyes, the doctor will see what is the actual normal situation inside the eye. Because what is normal is not fixed. All of us have different rates. So what is normal is variable. What is normal for me may not be normal for you. So it is best to get an idea of what is normal for you. So as soon as a patient is diagnosed with diabetes, it is advisable to check the eyes, at least within the first 1 month of a confirmed diabetic diagnosis. So in that time, the doctor will see your vision, he will check the eye pressure, he will see the lens whether you have cataract or not, and of course he will check the retina to see whether diabetes has affected the retina. Because a diagnosis of diabetes can be made even after 5-6 years of a patient being diabetic. A patient may not be knowing that he has got diabetes. But when you check a patient's blood for diabetes, he may be having 200, 300 level of blood sugar. And it is often seen that the patient has been having diabetes for 4-5 years and it has been unnoticed. So the first time you check whether you have diabetic retinopathy, you might actually have diabetic retinopathy. So even if you don't have diabetic retinopathy, it is wise to go for a checkup. So I shall now show you what is a normal picture of a retina taken with the help of a fundus camera. This is called a fundus camera, where a patient undergoes dilatation of the eyes, where you put drops in the eye and the pupil is dilated, and an eye doctor can check the photographs taken with this machine. So this is the photograph of a normal retina. So these are the blood vessels. This is called the optic nerve. This yellow spot is called the optic nerve. This is not actually yellow, but looks yellow compared to the pink surrounding of the retina. So this is the optic nerve. That is the optic nerve that is coming from the brain. This is the point where all what you see is transmitted to the brain. This dark spot is called the macula, where you see fine vision. And all the blood vessels support this area. So when I look at you or another person, I see the face with this area, and all what is surrounding in the room or any other people sitting with you are seen by these areas. But everything finally has to go through here to the brain. So any disease that affects this part or this part can affect our vision. But any disease that affects this part will not be noticed for you, because that is not the point of the retina where you are using to see what you are seeing actually. Actually, this area is to see the surroundings, and we might actually not be aware of what we are missing in the surroundings. So it is very important to get a picture taken to see the entire retina, whether it is normal or not. And how do we see the actual representation of the vessels? We have a test called angiography. The same thing what is used in cardiac angiogram, but that is to image the heart. The eye angiography is very simple. All what we have to do is take an injection into the arm and then take photographs. Unlike a cardiac angiogram, the patient need not be admitted. And it is not a major invasive procedure. So once the dye called sodium fluorescein is injected inside the eye, we darken the room and take photographs. This is the angiogram picture, which shows the blood vessels clearly. Now they are white in color because this is a black and white photograph, and the dye, that is the sodium fluorescent dye which we injected into the arm, is white in color because it fluoresces. So all the blood vessels are now clearly visible. If there was even a slight bleeding of any blood vessel, it would be shown as a white outpouring from one of these blood vessels. So it's very easy for a patient to know or a doctor to know whether they got diabetic retinopathy. Now let us consider some people who have got diabetic retinopathy. Now this is a patient who has got diabetic retinopathy. Now you can see the retina is faded, it is not pink anymore, it is sort of orange crimson, and we see some yellowish deposits here. Now these yellowish deposits are lipids, cholesterol. But diabetic retinopathy means a patient who has got diabetes. That means your blood sugar is high. How did cholesterol come here? Very simple. Diabetic retinopathy causes our blood vessels to leak. So when the blood vessels leak, blood comes out. And along with the blood, sugar, cholesterol, and all the cells come out. So, and they start depositing here. And after some time, our body, our retina uses up the blood sugar and the blood disappears. But the fats, are insoluble. They get deposited there. And fat is yellow in color. So that is what we see here, deposited. So these are cholesterol deposits that appear in diabetic retinopathy because of the reason I told you. So a diabetic patient should always check their cholesterol level because a high triglyceride level may also interfere with your diabetic retinopathy treatment. So these are nothing but fats. Now let us see how this appears on angiography. This is the angiography picture of the same patient. Now you can see various white spots here. Now these white spots are the places where the blood vessels are leaking. These hot white spots or the intense white spots are the areas of high leaking. But you saw in the color picture, this is the only area we thought was leaking. But you can see in the angiograph, that is not the only area, there are other areas. So that is the advantage of taking an angiogram. You will see those areas which you can't see on a natural photograph or when a doctor sees with the natural eyes. So all these spots now are spots with leaking. Now what is the treatment for this? The treatment is very simple. If it is at an early stage, it's very simple. All you have to do is control your diabetes. Most people I've seen check only the fasting blood glucose level. And any patient who checks, if you see randomly, 60% of them will have a fasting blood glucose of 120, 130. Though they will think controlled. The very same patient, when they go for a blood glucose level checkup, after taking food, will have 250, 260. So patient get a false sense of security by checking only their fasting blood glucose, that is FBS. So FBS might be normal, but the PPBS or the blood sugar after food may actually be very high. So ideal situation is you check both. Now if you don't have time to check on the same day, check fasting blood sugar today. You may have a glucometer at home with you. Check the fasting sugar today and check the after food tomorrow. At least twice a week you should be doing this. 2 readings per week of fasting blood glucose level, 2 readings per week of after food, that is called PPBS. That is one of the methods to control diabetic retinopathy, that is control your blood glucose. The other and the most significant is physical exercise. You will notice that I have not told you to cut down your intake of sugars because that is the least important thing. What is most important is to control your blood sugar either by medicines, but I would prefer that a patient take insulin because insulin is natural. It occurs in the body. It is not a chemical. As you know, all diabetic tablets are chemicals. But when you need to take tablets, you need to take. But first preference is always insulin. A tablet is a chemical. And any chemical has an effect and an undesired effect. That is called side effect. And most of the tablets for diabetes either affect the kidney or the liver. As you know, diabetes affects the eye, the kidney, the heart, and the nerves. How does it affect the eye? Diabetic retinopathy or cataract or glaucoma. How does it affect the kidney? Diabetic nephropathy. How does it affect the heart? Diabetic cardiomyopathy. Or you can have heart attack, silent heart attack it is called. The patient with diabetes will not know the pain of a heart attack. And a patient who has diabetic retinopathy, diabetic neuropathy, that affects the nerves, will have less sensation. So he will not know whether there is a tiny prick cut on the foot. And that might get infected. Patient will still not notice it because there is no pain. And you might end up losing a toe or a leg. So if you can recollect, I told diabetic nephropathy as the second problem. You're taking a tablet that will affect your kidney. And you also have diabetes that will affect your kidney. So it's a double insult on the kidney. Insulin has no such undesired effects other than a fall in glucose level if you take too much insulin. But you're going to take a fixed insulin dose that your doctor has suggested for you. Now, how will a patient have hypoglycemia or low glucose? If you consume less food than you normally take. That is the only reason. Or if you suddenly start exercising. So ideal way to control diabetes is either insulin or reduce your carbohydrate intake. You can take proteins. Reduce your carbohydrate intake, but importantly, you should exercise. If you walk for 20 minutes a day, that will be the best thing you can do for you. And I've seen many patients who tell me, I don't have the time to walk. I ask why? No, morning walk is difficult. It is raining in the morning. It is windy in the morning. But it is not a rule that you have to walk in the morning. You can walk even in the evening. And you need not walk on the road. I always tell my patients, I insist that you don't walk on the road because you might get bitten by a dog or hit by a bus. You can walk in the front courtyard of your house. Or you can drive to one public stadium and walk there. Or a park and walk there. Those are things you can do very easily. Walking on a front courtyard is the very easy thing you can do. And for patients who have diabetic neuropathy who say they can't walk, try to walk with a walker or a walking stick. So these are the ways you can control diabetic retinopathy. The other treatment part of it is, suppose it is not working out within 3-4 weeks, you go for laser. And there are many misconceptions about laser. In olden days, laser was actually a sort of firepower where we used to burn the retina. Now it is no more like that. A laser is nothing but a green light. And that induces a local coagulation. That means the blood clots there. With accompanied slight increase in temperature because it is a coagulation. And it has no other undesired effects. So a doctor will photocoagulate, that is laser coagulate this particular area where it is leaking and nowhere else. And that particular area gets healed. Now let's see another patient. Now this is another patient with diabetic retinopathy with the yellow deposit still. Still another patient with the yellow deposit, not so evident as in the other patients. But you go for the angiography, there are more bleeding sites. This is another patient with a lot of yellow spots. You see the angiography, you can see it is not leaking that much. So there is no rule that what you see clinically may be what the angiography tells you. Because here if you see there is a leaking. The actual yellow deposit was here, even though there are only pinpoint leaks. So that is why an angiography is very critical. It helps a doctor to know what is the actual state of the disease and also do the treatment. Now let's go back to the first patient. Now this was the first patient who had significant yellow deposits. We did the angiogram. Now I told you the treatment is control diabetes and then do laser. This is the result. Now you can see the yellow deposits which you could see here have now diminished. So laser has worked. Now if this patient has to remain like this, diabetes has to be controlled very well. Laser one time is not a cure for everything, because laser only cured what the present condition was. It does not guarantee that another leaking may not come. That depends on you, the patient. If your blood glucose level is under very good control and you do exercise properly, another leak may never come. But if the diet is not controlled, another leak will come and subsequent laser treatment is necessary. So patients always ask me, why do I have to keep on doing laser year after year? Is there any harm to doing laser year after year? The answer is very simple. As long as you have diabetes, you have the tendency for bleeding vessels in the retina. And if the diabetes is not under control, it will leak again and again. As often as it leaks again and again, laser is needed. So every year if it leaks, every year laser is necessary. And if you stop doing laser, the leak gets worse and worse. Finally the vision suffers. And we'll come to a stage where injections are necessary inside the eye. Now when you hear injections, you're terrified. But that is a treatment that is final. And if you realize there is no treatment for diabetic retinopathy in surgery, that is 100% successful. Because surgery itself is the last resort. So which are the conditions where surgery might be necessary? Let's see that. Now, these are some patients who have got frank blood. See the blood, red color here? This is frank blood. Now these are the yellow deposits. Those are the leaks that happened over a time. Slow leaks, and the blood absorbed and the yellow deposits are left behind. That can be done with mild laser. Now these are the heavy bleeding. That means the blood keeps on coming, so it remains red in color. There is no time for the eye to absorb it. Keeps on coming. So you have to do a large amount of laser to stop it. Or you have to do an injection immediately that will solve this problem. Sometimes injection may not work because the blood may be so severe and you have to do a surgery to evacuate the blood. And when we do a surgery to evacuate the blood, we have to do surgery near the retina. And we take out the blood, we take out the jelly, the vitreous jelly which was supporting the nerve, and we put in an oil to keep the eyeball in shape. Because eye, you know, is filled with water or a jelly. Now we have to replace that jelly with oil. And the vision will never be the same again. Though it will be much better than how you were before the surgery. But it can never return to normal. So, we should be treating diabetic retinopathy even before this sort of things happen. This is the angiography of the patient. Now we saw the blood, and this is the area where it is leaking. This is a large area, white area we can see here. And this is the picture on top. See, again, new vessels are formed here and it is leaking. So in diabetes, what happens is some areas now are deprived of blood because it is leaking here and it is blocked. So what does the nerves try to do? Some areas don't have blood now. So it will try to grow new vessels. And these are the new vessels. But that happens over a short period of time. The retina tries to make new vessels. And they are never as strong as our original vessels. So when we sneeze, or when we take heavy weights, or when we fall down, or when we cough, these bleed. So this has got proliferative diabetic retinopathy where new vessels are suddenly forming. That is the most dangerous thing that can happen to anybody's eye. Because even if you sneeze, this will bleed. And the bleeding is like a rain, torrent of blood. It may not be amenable for laser. At this stage also we can try laser. We can close these blood vessels. But there is no guarantee that laser might work fully. Because there is already significant damage in the retina for this to happen. So ideal situation is when we treat our diabetic retinopathy as soon as it comes. So this is another patient who has been treated. Now the bleeding has gone. But still you can see with diabetic retinopathy there are mild white spots, but the heavy bleeding has gone. This is another patient. I told you this is the optic nerve. Now that has grown new blood vessels. These are faint blood vessels here. Now let's see the angiography of that. See the heavy bleeding here? And that has happened on the optic nerve. That is even more difficult to treat because it is no more on the retina, it is on the optic nerve that is now connecting to the brain. So we will require a laser, but we can't do laser on this because it's the most critical part and the laser will not work here. We have to do laser on the surroundings. Might have to take a neurologist's help. Now 2 branches of medicine have come in. And you know, when more than one branch of medicine comes in, things are very serious. So in order to escape all this, the best way is to treat the diabetic retinopathy at the earliest.